Hyperkalemia. Like hypokalemic disorders, a high serum potassium can occur in the setting of normal or altered body stores of potassium. Pseudohyperkalemia is an in vitro phenomena due to mechanical release of potassium from the cells during phlebotomy procedure, specimen processing, or in the setting of marked leukocytosis and thrombocytosis. Causes for true hyperkalemia include excessive dietary intake, cellular redistribution, and decreased renal excretion of potassium. Excessive dietary intake. In the presence of normal renal and adrenal function, it is difficult to ingest enough potassium in the diet to produce hyperkalemia. Dietary intake of potassium as a contributor to hyperkalemia is usually observed in the setting of impaired kidney function. Sources high in potassium include watermelons, citrus juice, commercial salt substitutes containing potassium. Cellular redistribution. Tissue damage is probably the most important cause of hyperkalemia due to redistribution of potassium out of the cells. This can be due to rhabdomyolysis, trauma, burns, massive intravascular coagulation, and tumor lysis syndromes. Mineral acidosis, ammonium chloride or hydrogen chloride, by virtue of relative impermeability to the chloride anion, results in greatest efflux of potassium from the cells. By contrast, organic acidosis such as lactic acidosis or beta-hydroxybutyric acidosis result in no significant efflux of potassium. Decreased renal excretion of potassium. This can occur because of a primary decrease in the distal delivery of the salt and water, or an abnormal cortical collecting duct function, and a primary decrease in mineralocorticoid levels. Primary decrease in distal delivery. Acute decreases in glomerular filtration rate that occurs in acute kidney injury lead to marked decreases in distal delivery of salt and water that may secondarily decrease distal potassium secretion. When acute kidney injury is oliguric, distal delivery of sodium chloride and volume are low, and hyperkalemia is a very frequent problem. When kidney injury is non-oliguric, however, distal delivery is usually sufficient and hyperkalemia is unusual. In chronic kidney disease patients, hyperkalemia is unusual until the GFR falls to less than 10 to 20 ml per minute per 1.73 meter square. In case of hyperkalemia with a GFR of greater than 20 ml per minute per 1.73 meter square should raise the suspicion of decreased aldosterone levels or a specific lesion in the cortical collecting duct. Decreased mineralocorticoid activity can result from disturbances that originate at any point along the renin-angiotensin-aldosterone system. One common example is the use of angiotensin converting enzyme or ACE inhibitors or angiotensin receptor blockers in patients with diabetes with hyporeninemic hypoaldosteronism. Distal tubular defects include interstitial diseases that can affect the distal nephron specifically and lead to hyperkalemia in presence of only mild decreases in GFR and normal aldosterone levels. Amiloride and triamterene inhibit sodium transport, which makes the luminal potential more positive and secondarily inhibits the potassium secretion. Spironolactone and eplerenone compete with aldosterone and thus block the mineralocorticoid effect. Clinical presentation of hyperkalemia. Hyperkalemia leads to depolarization of the resting membrane because of the potential across the membranes is in part determined by the ratio of intracellular to extracellular potassium. The heart is particularly sensitive to this depolarizing effect. Progressive changes of hyperkalemia on ECG are peaked T waves, widening of PR and QRS interval, development of sine wave pattern, and eventually ventricular fibrillation and asystole. In general, ECG changes appear at a serum potassium concentration of 6 milliequivalents per liter with acute onset of hyperkalemia, whereas the ECG may remain normal up to a concentration of 8 to 10 milliequivalents per liter with chronic hyperkalemia. Hyperkalemia can also cause neuromuscular manifestations such as ascending paralysis and eventual flaccid quadriplegia. Hyperkalemia also decreases the ammonia availability to act as a buffer for distal hydrogen secretion. This effect impairs bicarbonate regeneration, leading to the development of normal anion gap metabolic acidosis. So how do we treat acute hyperkalemia? The immediate treatment of life-threatening hyperkalemia is the administration of calcium, usually in the form of calcium gluconate or calcium chloride. ECG changes such as increasing PR interval or widening QRS complex warrant treatment with calcium. Glucose and insulin therapy will shift potassium ions into the cells. Acute administration of glucose without insulin can potentially worsen hyperkalemia in patients with diabetes mellitus by raising extracellular osmolality and causing potassium to shift into the extracellular space. Sodium bicarbonate administration through expansion of extracellular fluid volume results in dilution of serum potassium. Potassium is shifted into the cells whenever concomitant metabolic acidosis is corrected. Inhalation of beta-2 agonists such as albuterol or parenteral use of salbutamol can cause significant potassium shifting into the cells. The effects of calcium, bicarbonate, glucose and insulin, and beta-2 agonist therapy will provide immediate relief for acute toxicity, but it does not decrease the total body potassium. So the measures needed to reduce the total body potassium include administration of potassium-binding drugs and dialysis. Treatment of chronic hyperkalemia. After review of patient's medication profile, drugs that can impair renal potassium excretion should be discontinued if possible. These include non-steroidal anti-inflammatory drugs. Patients should be placed on a low potassium diet with specific counseling against the use of potassium-containing salt substitutes. Diuretics are particularly effective in minimizing hyperkalemia. In patients with eGFR of less than 30 ml per minute per 1.73 meter square, thiazide diuretics can be used, but loop diuretics are required with more severe renal insufficiency. In chronic kidney disease, patients with metabolic acidosis, sodium bicarbonate should be given. Potassium-binding drugs can be utilized whenever hyperkalemia is refractory. Sodium polystyrene sulfonate, also called caecylate, is available but it is poorly tolerated, leading to GI toxicity. Patriomur and sodium zirconium cyclosilicate are new potassium-binding drugs that are well tolerated when used in chronic hyperkalemia.